In this PowerPoint, we'll be looking at how upper motor neuron lesions differ from lower motor neuron lesions in the presentation of symptoms. In understanding the difference in symptoms between upper motor neuron lesions and lower motor neuron lesions, we'll need to first review spinal cord reflexes and basically the neuroanatomy of these reflexes, how they work. So if going back to your neuro, if you recall what a spinal reflex refers to, and there's the components involved in the spinal reflex arc are the sensory receptor. It doesn't matter what the receptor is in the periphery. When it fires, it'll send its sensory information. Its action potential will travel along that sensory afferent neuron back to the spinal cord in that spinal nerve. And once in the gray matter, it'll synapse onto an interneuron. And the interneuron will then process that sensory information, and then it'll synapse onto the motor efferent that comes right back out of that spinal nerve and supplies the target tissue, the skeletal muscle. So this is called the spinal reflex arc, or it's a spinal reflex because the processing or integration of that sensory information occurs in the spinal cord at that level. Okay, so integration occurs within the spinal cord. And so when you have these sensory receptors firing, remember there'll be more than one of these receptors firing. Let's say it's pain. Let's give an example where you've put your hand on a hot stove, okay, and nociceptors are firing because of the painful stimulus. So some of these nociceptors will send their information along these sensory afferent neurons and synapse onto an interneuron, synapse onto a motor efferent, right back out to the skeletal muscle, and this is what makes you take your hand off the hot stove immediately in that spinal reflex. Some of the nociceptors that are firing will send their information in sensory afferent neurons that will synapse onto ascending pathways, bringing that sensory information up to the brain. So this is why you're aware that your hand is on a hot stove. You're aware of the pain, perception of pain. So that information does have to be sent to the brain so that there's awareness of what's happening. The brain will then send descending pathways back down, motor pathways back down here that will influence this synapse. So in effect, it's going to influence this reaction, okay, from this motor efferent, the motor efferent signals that are coming back out to the skeletal muscles. Okay, and how it primarily influences those motor efferents is to suppress or tone down the reflex. Okay, so to think about this, it's to make this reflex more controlled. All right, so the spinal reflex is going to occur. It doesn't need the brain to do this arc, okay, but the brain does influence this motor efferent reaction, and primarily what it does is it tones it down. Okay, so another name for this motor efferent here, this motor neuron, is the lower motor neuron. Okay, so the cell body for the lower motor neuron is in the gray horn here in the spinal cord, and it continues back out in the spinal nerve and synapses onto its target tissue, the skeletal muscle. This is the lower motor neuron. The upper motor neuron will be this descending motor pathway coming back down that's influencing the synapse. Okay, so to understand, when you have, let's say, lower motor neuron problems, and we'll go through this in a little more detail shortly. So lower motor neurons run in spinal nerves, that's these motor efferents, and as well cranial nerves and peripheral nerves. Okay, so when you have a lower motor neuron problem, there's an issue either with a spinal nerve or a peripheral nerve or with a cranial nerve. And so one way to think about it is that these motor efferents, these lower motor neurons, are being compromised or damaged or squeezed, cutting off the power supply to the skeletal muscle. Okay, so with this arc, you would have decreased tone in this muscle and a decreased response to this reflex. Okay, so as an example, if this was a deep tendon reflex that we'll look at in a little more detail shortly, Okay, if the sensory receptor here was the muscle spindle, which is the receptor for the deep tendon reflex, if you did a patellar reflex on somebody, it's the muscle spindles in the quadricep muscle that's going to fire. Okay, and that's going to set up this reflex arc back in that spinal nerve to the spinal cord, and the lower motor neurons coming back out will make the quadricep muscle fibers contract. So if there's a problem with the lower motor neuron, then you lose power to that skeletal muscle. So the reflex, the deep tendon reflex, would be diminished, decreased, because you've lost power to the skeletal muscle. On the other hand, if you have an upper motor neuron problem, so that would include this descending motor pathway here that's damaged. Let's pretend there's a problem in the spinal cord that's damaging this tract. The spinal reflex is still going to work. Okay, it's not affected by that, by damage to the spinal cord above that level. Okay, but what is happening is that this descending pathway is being damaged. So you're going to lose the inhibition that this descending pathway normally has on this synapse. Okay, so if you lose inhibition, that means that this reflex will be exaggerated. Okay, remember that primarily these descending pathways will suppress or tone down the reflex. So if the descending motor pathways, these are the upper motor neurons, if they're damaged, you lose the inhibition that they normally provide at this synapse. So now this reflex is exaggerated. And this is one of the reasons why you see increased muscle tone and increased deep tendon reflexes, hyperactive reflexes with upper motor neuron lesions. Okay, so that's an important concept to understand. We'll go across, or we'll go over the deep tendon reflex in a little more detail shortly. But this is the basic premise. These spinal cord reflexes, how they're influenced by these descending pathways, and understanding when you have an upper versus lower motor neuron lesion, what these reflexes will look like. Okay, so again, spinal reflexes are involuntary motor responses, so you don't have control over these. And again, a deep tendon reflex is an example of a spinal reflex, and you know when you do a deep tendon reflex on somebody, they can't control that reflex. It's an involuntary motor response. Okay, and so again, the stretch reflex, the deep tendon reflex, is an example of a spinal reflex, and this we'll see in the next slide. Will show the image of this, but the result is the contraction of the muscle fibers when a muscle is passively stretched. And this is an important point. The stretch reflex is essential for posture and muscle tone in the body. And muscle tone refers to the resting state of a muscle. So even when a muscle is at rest, it's not being used, there's a tone to that muscle. And that tone is established by the constant action of the stretch reflex that occurs in these muscle groups. Okay, you should know that the receptor for the stretch reflex is the muscle spindle, and again, we'll see that more clearly next slide. And you need to know this definition. Muscle tone equals the continuous resistance, or is due to the continuous resistance to passive stretch provided by continuous activity of the stretch reflex. Okay, so as a very simple explanation or example, we'll compare quadriceps and hamstring muscles. So if you're standing upright to keep you in balance, if you're starting to, let's say, sway forward, and we're going to exaggerate this, let's say you're standing up and you're swaying forward, so now there's a passive stretch happening of the hamstring muscles as you sway forward, and the muscle spindles now in the hamstrings will fire, and that will cause the hamstrings to contract and pull you back. And if you go too far back, then the muscle fibers in the quadricep muscles will passively stretch, causing the muscle spindles to fire, causing the quadricep muscle to contract to pull you back again. So that's an exaggerated example, but this is what happens constantly in the body between agonist antagonist muscle groups. They have these stretch reflexes that are fine-tuning, constantly working and maintaining tone and maintaining posture and balance in the body. Okay, so you have to know the definition. Tone, muscle tone. Again, muscle tone refers to the state of a muscle when it's at rest. There's a tone to it, and it's due to this continuous resistance to passive stretch of the muscle fibers provided by the continuous activity of the stretch reflex. Okay, in this slide, we're going to go over the stretch reflex, just a quick review. And remember, one example of the stretch reflex are the deep tendon reflexes in the body. So we'll use the patellar reflex as an example, illustrating how stretch reflexes work. So in this case, so we hit the patellar tendon with the reflex hammer. When we hit the tendon, we're actually going to cause a microscopic stretching of the quadricep muscle fibers, and that will cause the muscle spindles. These are the receptors for this reflex arc. The passive stretch of the muscle fiber will cause these muscle spindles to fire. So then we have an action potential that's going to be sent back in the spinal nerve from this level back to the spinal cord. And once in the spinal cord, we're going to have a synapse onto a lower motor neuron that comes right back out, okay, right back to the quadricep, so it's in the same muscle group as the muscle spindles are located, and it'll cause that muscle to contract. So that's the response. Okay. At the same time, we have another synapse that will also be inhibitory to the antagonist muscles, which in this arc will be the hamstrings. So it'll inhibit the hamstrings from firing. All right. So the overall effect is that the knee will go into extension due to firing of the quadricep muscle. Okay. So that's your basic reflex arc, and in the stretch reflex. What we see here also is that when that sensory information comes in, some of these sensory afferent neurons will send their information into a tract that will go up to the brain so that the brain is aware of this process happening, of this reflex occurring. And what this image doesn't show is that the brain will influence this synapse, okay, like we saw on the previous slide. It'll send down descending pathways that will influence this synapse to tone down this lower motor neuron response. Okay, so when everything is working properly, if there's no problem with the lower motor neuron, there's no problem with the upper motor neuron. And remember that the descending pathway that would be coming down would be a motor pathway, and it would be the upper motor neuron. Okay, so if everything is working well, then we have a nice controlled deep tendon reflex when we do this stretch reflex. If there's a problem with the lower motor neuron, okay, so if we have a spinal nerve compression or a peripheral nerve compression that these lower motor neurons are running in, then we're going to cut off the power supply, one way to think about it, to this quadricep muscle, and as a result, the reflex will be diminished. You won't have as strong a reflex when you do this DTR. Okay, so that's what you see with lower motor neuron problems. If it's an upper motor neuron problem, which means there's a problem either in the spinal cord or up in the cerebral cortex where this pathway starts, this descending motor pathway starts coming down, even though the spinal reflex is still working, okay, so if there's a spinal cord problem above this level of the spinal cord, the spinal reflex is still working. All right, but now you're going to lose the inhibition that descending pathway normally has on this synapse. So as a result, this deep tendon reflex will be exaggerated. Okay, there will be no control, no suppression of this lower motor neuron response, and the quadricep contraction will be very strong. So that's why you see deep tendon reflexes will be hyperactive, okay, with upper motor neuron lesions. Okay, so just make sure you understand why you see increased deep tendon reflex with upper motor neuron lesions, why you see a diminished deep tendon reflex with lower motor neuron lesions. This slide will very simply illustrate upper versus lower motor neurons. So the lower motor neurons are the motor efferents that run in spinal nerves and also in the cranial nerves that carry motor fibers, and as well in the peripheral nerves. Remember, peripheral nerves are two or more spinal nerves running together. Okay, so that's where we find the lower motor neurons. Those are the motor efferents that run in those nerves. The upper motor neurons begin in the motor cortex of the brain. Okay, and that's where the cell bodies of these axons start, and they are primarily made up of the corticospinal tracts. All right, so the corticospinal tracts are your voluntary motor tracts. That when you want to initiate a voluntary movement in the body, it starts in the motor cortex. That signal is then sent down the corticospinal tracts into the spinal cord. And remember that these tracts cross over in the brain stem. So this is why the right side of the brain controls the left side of the body and vice versa. Okay, so that corticospinal tract will come down, it'll descend, it'll synapse onto the lower motor neuron, and then that will go out to the skeletal muscle to fire those muscle fibers. So if you want to initiate voluntary movement, if you want to move your arm, that starts in the motor cortex. That signal is sent down the corticospinal tract, your voluntary motor tract, which then excites the lower motor neuron to fire the skeletal muscle to be able to move your arm. Okay, so the upper motor neuron is the corticospinal tract, and when you have a problem with the upper motor neuron, it could either be up in the brain, affecting the motor cortex if there's damage. If somebody has stroke, for example, that damages anywhere along this pathway in the brain, or once we're in the spinal cord, any spinal cord lesion that's damaging this pathway, okay, will cause an upper motor neuron lesion and presentation of symptoms. What we don't see in this image is a reflex arc. So remember that the corticospinal tract, these upper motor neurons, will also influence reflexes so that it tones down, it suppresses the reflex, if this was the deep tendon reflex coming out to the skeletal muscle here. Okay, so the upper motor neuron is excitatory when you want to do voluntary movement to act on the lower motor neuron, and it's also inhibitory to suppress or to tone down the reflex when you're dealing with spinal reflexes like deep tendon reflexes and the stretch reflexes that establish muscle tone in the body. So then when you have upper motor neuron lesions, there's either can be a problem in the motor cortex of the brain itself or anywhere along that descending corticospinal voluntary motor pathway. Okay, so into the spinal cord as well. If there's a spinal cord lesion affecting that descending corticospinal tract, then this will create an upper motor neuron lesion. Okay, an important point here is that the lower motor neuron spinal reflexes are still working. They remain intact, but now they're not being influenced by the damaged upper motor neurons the way they should be influenced. So there could be loss of excitatory action. So if you're trying to voluntarily move a limb, that's going to be hampered by an upper motor neuron problem. As well, you're going to lose the inhibitory input from those upper motor neurons on the spinal reflexes. All right, so the spinal reflexes, like the stretch reflex that establishes muscle tone, and the deep tendon reflexes that we see, are going to lose that inhibition that those upper motor neurons normally provide. So when there's an upper motor neuron problem, especially if it's a significant problem that, let's say you have actually a spinal cord lesion or severe damage to the spinal cord, you may see immediate weakness first, loss of motor control to the muscles, and loss of fine motor control. And then with upper motor neuron lesions, this is hallmark symptom, the weakness will become hypertonicity or spasticity. So this is increased muscle tone. And this is what you see with upper motor neuron lesions. And again, this is going to be because the suppression of or the inhibition that normally acts on the spinal reflexes, like the stretch reflex, is being lost. And so we have increased muscle tone in the body, increased response to the stretch reflex, and that results in hypertonicity, spasticity of muscle groups, as well as increased deep tendon reflexes. On the other hand, when you have lower motor neuron lesions, there's a problem between the spinal cord and the target tissue, the muscle. So the motor efferents will be disrupted, and so this will affect the voluntary motor to that muscle as well as the reflexes, the spinal reflexes like the stretch reflex, which maintains muscle tone, will be affected as well. In the most extreme example, if you have total denervation of the muscle, so if the nerve has been cut, for example, to the muscle, then you would have a flaccid paralysis. You would be unable to move the muscle, and the tone would be very flaccid, the muscle tone. Didn't mention this on the last slide, but if you were to actually cut the spinal cord right through, and you have a complete upper motor neuron denervation of voluntary muscles, it would result in a spastic paralysis. So you'd be paralyzed, you wouldn't be able to move, but the muscle tone would be hypertonic, would be spastic. Okay, lower motor neuron lesions, if it's a complete lesion, results in a flaccid paralysis. So you would have a total loss of reflexes, including the deep tendon reflex, and total weakness, atrophy of the muscle group. So we see this with peripheral nerve injury as well. So peripheral nerves like the median nerve, the ulnar nerve, the sciatic nerve. When you have, and remember, in the peripheral nerves, that's the lower motor efferents are also running in peripheral nerves, and those spinal nerves that make up the peripheral nerve. So when you have a peripheral nerve problem, it's lower motor neuron presentation. So you'll see muscle atrophy and weakness, decreased tone of the muscle, and diminished or loss of the deep tendon reflexes, spinal reflexes. We'll make a point here. What you can also see with lower motor neuron lesions, so if there is something that's irritating the lower motor neuron, the motor efferent in that spinal nerve, if there's a compression, infection, something that's irritating the nerve, it can create the nerve or create a state of the nerve that it's in a hyperexcitable state, which means that it's more easily irritated to fire or stimulated to fire. And so you may see these spontaneous contractions of muscle units within the muscle that's known as fasciculations. So you can see this, it's quite common with lower motor neuron, peripheral nerve, spinal nerve irritation. It'll cause little twitching, little fasciculations in the muscle. These are not to be confused with hypertonicity. Okay, so remember, lower motor neurons are associated with hypotonicity, decreased muscle tone, but you still may see these fasciculations due to hyperexcitability of the muscle fibers because of the irritation of the lower motor neuron, but this is not hypertonicity. Perhaps we're overemphasizing this again, but last slide here just to illustrate where you can have trauma that affects either upper or lower motor neurons. So upper motor neuron lesions, there could be something up in the brain. So for example, stroke, cerebral infarction, damaging the pathway or the motor cortex, or somewhere along the pathway into the spinal cord, affecting the corticospinal tract. Okay, so that results in the upper motor neuron lesion. Lower motor neuron lesions then will be, if it's just the one spinal nerve, a nerve root, the problem typically occurs at the spine. So it could be a disc lesion, space-occupying lesion, an osteophyte, and significant osteoarthritis can compress the spinal nerve. And if it's just one spinal nerve, the problem needs to be at the spine itself. Because shortly after leaving the spinal cord, the spinal nerves come together to form the peripheral nerves. Okay, as an example, the median nerve is made up of C5, C6, 7, 8, and T1 spinal nerves. So for a peripheral nerve compression to occur, or a problem, it has to be distal from the spine. Okay, because as we get close to the spine, at the spine, it's just going to be one spinal nerve that's typically having a problem. But if it's a peripheral nerve problem, the entrapment has to be distal from the spine, where the peripheral nerves are formed from two or more spinal nerves now traveling together. Okay, so there are different things that can cause muscle tone issues in the body. So for example, there's a problem with the stretch reflex itself. Remember that the stretch reflex, the muscle spindle reflex, is the reflex, that spinal reflex, that establishes muscle tone in the body. There may be a problem at the neuromuscular junction itself. So where the lower motor neuron synapses onto the skeletal muscle fibers, if there's a problem at that synapse, it'll cause a problem with muscle tone. There may be a problem with the skeletal muscle itself, so there's nothing wrong with the neurology. Upper or lower motor neurons are fine, but if the muscle can't respond to the innervation, for example, in muscular dystrophy, like in Duchenne's or Becker's muscular dystrophy that you would have learned about, then muscle tone will obviously be affected. There could be spinal cord injury. So again, if it's a spinal cord injury or a brain injury, it's an upper motor neuron lesion presentation. There could be a problem at the spinal nerve root, so at the level of the spine. This will cause a lower motor neuron presentation, or it could be an entrapment of a peripheral nerve, like carpal tunnel syndrome, for example, and this will be a lower motor neuron presentation. Okay, so all these things are possible causes of altered muscle tone in the body. As a general definition, hypotonia. Okay, so hypo means less than tone, less than normal tone. All right, and this is going to, so this, make sure you know this, hypotonia is due to reduced excitability of the stretch reflex, the muscle spindle reflex. Okay, if that stretch reflex is diminished, then you have less muscle tone in the body, okay, or of that muscle. Hypertonia, on the other hand, refers to an abnormal increase in muscle tone, and this is associated also with hyperactive deep tendon reflexes, DTRs. This is what you see in upper motor neuron lesions, and this includes spasticity and rigidity. We'll see on the next slide these types of examples of hypertonia a little more. But these are all representative of hypertonia: spasticity, rigidity, hyperactivity of muscle, and muscle tone and deep tendon reflexes. Okay, so that's representative of upper motor neuron lesions. Hypotonia is associated with lower motor neuron lesions. Okay, a little more detail concerning disorders of muscle tone. So what's associated with upper motor neuron lesions? Remember, this is you're going to see hypertonicity of muscle tone with upper motor neuron lesions. And examples of hypertonicity are rigidity, spasticity, and clonus. And I'll post some videos within Blackboard to illustrate these different types of hypertonicity. Rigidity is, there's two categories: lead pipe rigidity and cogwheel rigidity. Lead pipe, when you think about lead, is a soft metal, so when you're trying to move a joint, that in somebody who has lead pipe rigidity, let's say trying to bend the elbow, there's a resistance through the full range of motion, like you're trying to bend a piece of lead. Cogwheel rigidity refers to more of a catch and release type of movement that occurs through the range of motion. Again, I'll post videos to kind of illustrate this, these two types of rigidity. Okay, and so again, when you're dealing with hypertonicities, you're seeing this in upper motor neuron lesions. There's an increase in the activation of the lower motor neurons that's causing this increased muscle action. And this is because of a decrease or loss of inhibition from those upper motor neurons that have been damaged. Spasticity, also known as clasp knife catch and release through a range of motion. I'll illustrate that again on a video. And clonus. Clonus you see, for example, if you were to very quickly dorsiflex somebody's ankle, it'll cause a flapping, a contraction, relaxation, flapping type of motion that you see of the ankle. So again, these are all, and I'll post an example of that as well. These are all examples of hypertonicity, so clonus, spasticity, rigidity, and this is what you see in upper motor neuron lesions. Okay, typically because you lose that inhibition that the upper motor neurons typically present or have acting on the lower motor neurons. On the other hand, with lower motor neuron lesions, you're going to have absent or decreased muscle tone, hypotonia, and this also translates into flaccidity. So if a muscle is flaccid, it's weak, there's decreased muscle tone. This is what you see in lower motor neuron lesions. The lower motor efferents are damaged or not able to activate the skeletal muscle fibers sufficiently, creating different or diminished tone. Okay, just to summarize then, the major differences between upper motor neuron and lower motor neuron lesions. First of all, muscle weakness. You see in both upper and lower motor neuron lesions. Muscle atrophy. So typically with upper motor neurons, you don't see atrophy initially, but over time, if it results in disuse and not able to use the muscle, it'll atrophy. Atrophy is definitely seen in lower motor neuron lesions, and it can occur quite quickly when there's a significant lower motor issue. Fasciculations, remember those are those little contractions due to hyperexcitability of muscle fibers. So you don't see fasciculations in upper motor neuron lesions. Remember, fasciculations are not examples of hypertonicity. Okay, this is just due to irritation or infection of the lower motor neuron, and this is what you see in lower motor neuron lesions, fasciculations. Okay, very important, reflexes, spinal reflexes, including deep tendon reflexes, are increased in upper motor neuron lesions and decreased in lower motor neuron lesions. And muscle tone, okay, increased in upper motor neuron lesions and decreased in lower motor neuron lesions. Okay, so you need to know these differences as a basic summary of what we've talked about in this PowerPoint.